Hi, and welcome to the first international online symposium on expert meeting for the best practice in fertility preservation. This symposium was initially planned to attract colleagues from Turkey and its surrounding countries. Besides its challenging scientific program, we had chosen a very attractive place, Istanbul, the city that combines not only the continents, but cultures that have shaped our civilization today. Now the technology helped us to overcome the negative effects of pandemic and to turn the organization into a virtual meeting. In its current form, the same challenging and attractive scientific content is now embedded with a virtual conference center where you can move around as if you are in a real meeting and join all attractions and events free from time and location-dependent restrictions. We have no doubt that attendees of our symposium will have unique experiences within the virtual symposium environment. Now that you have been through the registration process, let me briefly inform you and guide you how to navigate the virtual symposium environment. Although I can feel the crowd in the meeting, I don't need to worry about the queue in the registration or information desk. No need for social distancing and carrying a mask. In all meetings, attendees frequently look up the scientific program in order not to miss the presentation of his or her interest. So in this platform, you can simply click on the kiosk screen to view the main program anytime you like. Likewise, you have a question, all you need to do is to visit us from the info desk. Not to mention, you are welcome to send us email at any time you like. This is the invited faculty hall. As you can see from the scientific program, we host numerous international well-known speakers in the meeting. In a real meeting, one can hardly find a way to ask questions, but in this platform, it is something that you can easily do without a hassle. Even during the presentations, you can meet the invited faculties in this hall for your questions. Be sure that 19 fertility preservation experts from 8 different countries will be here to share their knowledge and experience with you for 3 days. Here, you can see the door for the conference hall, where main program lectures will be given. We will start live broadcasting on September 11th at 17:30 from conference hall. We have organized a very challenging scientific program, so please don't miss these featured presentations. But for some reason, if you do, all lectures will be recorded and be available for registered participants after the event. Fertility preservation requires multidisciplinary approach that can combine numerous other medical specialties, many experts from different societies. In the affiliated science societies hall, our attendees can find the booths and interact with different affiliated societies, get information, learn and follow their activities. You can also apply for a membership by just several clicks. To access the exhibition area, you will be clicking this door. Exhibition hall will be open 1 day before the Congress starts, so you would have enough time to visit the exhibition area, take a look at the booths and engage with the company representative to get more information regarding their products and services portfolio. We will be doing best for you to enjoy the meeting by keeping you comfortable from wherever you will be joining the meeting. We all look forward to welcome you on Friday, the 11th of September at 17:30 a.m. Central European Time. Thank you and looking forward to welcoming you in our symposium. In the meantime, I wish you good health during this challenging time. Thank you.
Dear guests, welcome to the first online international symposium on fertility preservation. As you all know, fertility preservation is a rapidly growing field of reproductive medicine. Turkish Society of Fertility Preservation Symposium Series aims to gather key clinicians and scientists who are expert in their fields in order to discuss the most relevant topics ranging from cryobiology, ovarian biology to ovarian stimulation protocols and artificial gonads. As the president of the Turkish Society of Fertility Preservation, I would like to welcome you one more time on behalf of myself and our board members. Thank you.
When you're constantly evolving and looking to make the world a better place, you never stop. That's why we'll never stop, building on our history to continue to transform the world of healthcare. We'll never stop saving doctors critical time by turning complex CT and MRI data into 3D images using our healthcare IT systems, which allows surgeons to create simulations before operations ever take place. Working to develop miniature endoscopes to ease patient anxiety during uncomfortable procedures, and point-of-care ultrasound machines that can travel to previously unreachable places. We'll never stop evolving visual imaging technologies engineered to help doctors identify difficult-to-detect diseases earlier. Pioneering the world of pharmaceuticals with advanced drug delivery technologies that use nanoparticles designed to target diseases. Advancing the field of regenerative medicine by applying cutting-edge development and production technologies to provide high-quality iPS cells, which contribute to cell therapy. Pushing the boundaries of biomedicine to help fight diseases like cancer and expand the possibilities of healthcare. And we're entering the fight against aging by using our antioxidant knowledge that prevents film from aging to help advance skin care. Of course, we're just getting started. We'll never stop improving the future by transforming healthcare through advancing the fields of medical prevention, diagnosis, and treatment. And we'll never stop creating value from medical innovation to make the world a stronger, healthier, more livable place. Never stop advancing healthcare. Fujifilm, value from innovation.
Experts from all over the world will be with us to discuss the basics, current state, and innovations of fertility preservation. Please don't miss this outstanding virtual symposium and mark your calendar from 11 to 13 of September. I will be there. Will you?
Mein Name ist Horst Wolf.
My name is Horst Wolf.
Ich bin im Hause Zeiss.
At SYMPOSIUM, I'm responsible for inverted research microscopes in life sciences.
Als Zellbiologe habe ich mir immer
As a cell biologist, I've always wanted a flexible imaging system that would let me perform all different kinds of experiments but still be easy to operate.
ein stabiles System, das vielen
A
unterschiedlichen
stable system that would create optimal conditions for a whole range of samples and deliver reproducible results every time.
mit
Axio Observer is everything I'd hoped for. It lets you combine a wealth of technologies with options to fine-tune it precisely to your experiments.
Sie nutzen die
It uses novel LED illumination for gentle and reproducible imaging.
Wählen Sie aus einem breiten
And you can choose the perfect objectives and contrasting methods for your applications from the wide-ranging Zeiss portfolio. Expand your Axio Observer with AutoCore, and you will always be imaging your samples with the highest resolution and best contrast. Definite Focus 2 focuses your sample automatically and keeps it sharp even during long-term time-lapse experiments.
Axio Observer ist Ihre
Axio Observer is your stable inverted platform for the challenge of imaging living or fixed specimens.
Weitere Informationen
For further information, visit our website.
Mein Name ist Horst Wolf.
My name is Horst Wolf.
Ich bin im Hause Zeiss.
At SYMPOSIUM, I'm responsible for inverted research microscopes in life sciences.
Als Zellbiologe habe ich mir immer
As a cell biologist, I've always wanted a flexible imaging system that would let me perform all different kinds of experiments but still be easy to operate.
ein stabiles System, das vielen
A
unterschiedlichen
stable system that would create optimal conditions for a whole range of samples and deliver reproducible results every time.
mit Axio Observer
Axio Observer is everything I'd hoped for. It lets you combine a wealth of technologies with options to fine-tune it precisely to your experiments.
Sie nutzen die
It
neuesten
uses novel LED illumination for gentle and reproducible imaging.
Wählen Sie aus einem breiten
And you can choose the perfect objectives and contrasting methods for your applications from the wide-ranging Zeiss portfolio. Expand your Axio Observer with AutoCore, and you will always be imaging your samples with the highest resolution and best contrast. Definite Focus 2 focuses your sample automatically and keeps it sharp even during long-term time-lapse experiments.
Axio Observer ist Ihre
Axio Observer is your stable inverted platform for the challenge of imaging living or fixed specimens.
Weitere Informationen
For further information, visit our website.
Mein Name ist Horst Wolf.
My name is Horst Wolf.
Ich bin im Hause Zeiss.
At SYMPOSIUM, I'm responsible for inverted research microscopes in life sciences.
Als Zellbiologe habe ich mir immer
As a cell biologist, I've always wanted a flexible imaging system that would let me perform all different kinds of experiments but still be easy to operate.
ein stabiles System, das vielen
A
unterschiedlichen
stable system that would create optimal conditions for a whole range of samples and deliver reproducible results every time.
mit
Axio Observer is everything I'd hope for. It lets you combine a wealth of technologies with options to fine-tune it precisely to your experiments.
Sie nutzen die
It
neuesten
uses novel LED illumination for gentle and reproducible imaging.
Wählen Sie aus einem breiten
And you can
Portfolio
choose the perfect
genau
objectives
passende
and contrasting methods for your applications from the wide-ranging Zeiss portfolio. Expand your Axio Observer with AutoCore, and you will always be imaging your samples with the highest resolution and best contrast. Definite Focus 2 focuses your sample automatically and keeps it sharp even during long-term time-lapse experiments.
Axio Observer ist Ihre
Axio Observer is your stable inverted platform for the challenge of imaging living or fixed specimens.
Weitere Informationen
For further information, visit our website.
Mein Name ist Horst Wolf.
My name is Horst Wolf.
Ich bin im Hause Zeiss.
At SYMPOSIUM, I'm responsible for inverted research microscopes in life sciences.
Als Zellbiologe habe ich mir immer
As a cell biologist, I've always wanted a flexible imaging system that would let me perform all different kinds of experiments but still be easy to operate.
ein stabiles System, das vielen
A
unterschiedlichen
stable system that would create optimal conditions for a whole range of samples and deliver reproducible results every time.
mit Axio Observer
Axio Observer is everything I'd hope for. It lets you combine a wealth of technologies with options to fine-tune it precisely to your experiments.
Sie nutzen die
It
neuesten
uses novel LED illumination for gentle and reproducible imaging.
Wählen Sie aus einem breiten
And you can
Portfolio
choose the perfect
genau
objectives
passende
and contrasting methods for your applications from the wide-ranging Zeiss portfolio. Expand your Axio Observer with AutoCore, and you will always be imaging your samples with the highest resolution and best contrast. Definite Focus 2 focuses your sample automatically and keeps it sharp even during long-term time-lapse experiments.
Axio Observer ist Ihre
Axio Observer is your stable inverted platform for the challenge of imaging living or fixed specimens.
Weitere Informationen
For further information, visit our website.
As a radiation oncologist, I invite all cancer professionals, including radiation, medical and surgical oncologists, to participate in this symposium, to hear and discuss the timing and current state of art in fertility preservation. Let's focus all together for the best possible functional survival. Looking forward to see you all together in this symposium.
Impril, mitochondrial micronutrients.
Hello, this is Dr. Karlıkaya. Dear guests, due to the time limitation and case-specific problems, specialized stimulation protocols are needed in fertility preservation patients. You can find the answer of your questions by joining to our symposium. You will have a chance to listen to the expert on this field.
Dear colleagues, we are hosting the most experienced physicians to talk about the current practices and future innovations in fertility preservation. Isn't it great? Move to a comfortable chair, grab your coffee and enjoy this wonderful session.
Hi, and welcome to the first international online symposium on expert meeting for the best practice in fertility preservation. This symposium was initially planned to attract colleagues from Turkey and its surrounding countries. Besides its challenging scientific program, we had chosen a very attractive place, Istanbul, the city that combines not only the continents, but cultures that have shaped our civilization today. Now the technology helped us to overcome the negative effects of pandemic and to turn the organization into a virtual meeting. In its current form, the same challenging and attractive scientific content is now embedded with a virtual conference center where you can move around as if you are in a real meeting and join all attractions and events free from time and location-dependent restrictions. We have no doubt that attendees of our symposium will have unique experiences within the virtual symposium environment. Now that you have been through the registration process, let me briefly inform you and guide you how to navigate the virtual symposium environment. Although I can feel the crowd in the meeting, I don't need to worry about the queue in the registration or information desk. No need for social distancing and carrying a mask. In all meetings, attendees frequently look up the scientific program in order not to miss the presentation of his or her interest. So in this platform, you can simply click on the kiosk screen to view the main program anytime you like. Likewise, you have a question, all you need to do is to visit us from the info desk. Not to mention, you are welcome to send us email at any time you like. This is the invited faculty hall. As you can see from the scientific program, we host numerous internationally well-known speakers in the meeting. In a real meeting, one can hardly find a way to ask questions, but in this platform, it is something that you can easily do without a hassle. Even during the presentations, you can meet the invited faculties in this hall for your questions. Be sure that 19 fertility preservation experts from 8 different countries will be here to share their knowledge and experience with you for 3 days. Here, you can see the door for the conference hall, where main program lectures will be given. We will start live broadcasting on September 11th at 17:30 from conference hall. We have organized a very challenging scientific program, so please don't miss these featured presentations. But for some reason, if you do, all lectures will be recorded and be available for registered participants after the event. Fertility preservation requires multidisciplinary approach that can combine numerous other medical specialties, many experts from different societies. In the affiliated science societies hall, our attendees can find the booths and interact with different affiliated societies, get information, learn and follow their activities. You can also apply for a membership by just several clicks. To access the exhibition area, you will be clicking this door. Exhibition hall will be open 1 day before the Congress starts, so you would have enough time to visit the exhibition area, take a look at the booths and engage with the company representative to get more information regarding their products and services portfolio. We will be doing best for you to enjoy the meeting by keeping you comfortable from wherever you will be joining the meeting. We all look forward to welcome you on Friday, the 11th of September at 17:30 a.m. Central European Time. Thank you and looking forward to welcoming you in our symposium. In the meantime, I wish you good health during this challenging time. Thank you.
Welcome to the first International Symposium on Fertility Preservation. I am Dr. Öktem, Professor of OBGYN at Koç University Hospital and the President of the Turkish Society of Fertility Preservation. We are excited to host this digital event where expert scientists and clinicians came together to discuss all aspects of fertility preservation. It's my pleasure and proud to announce that we have more than 500 participants from 45 different countries. I would like to thank the organizing committee or board of chairs and the supporting sponsoring companies to make this exciting event possible. I will keep this boring speech short and welcome you one more time on behalf of myself and our board members.
One of the board members of Turkish Society of Fertility Preservation. I'm going to chair this session with my colleague Kübra Boynukalın from Bahçeci IVF Center. Today we have two main sessions. In each session, 3 distinguished speakers will be with us. At the end of each session, we have 15 minutes for questions and answers. Invited faculty will be together to answer your questions. Even if we don't have enough time to cover all the questions, your questions will be answered and sent to your email. If your question is to a specific invited faculty, your questions will be emailed to them. Our first speaker is Dr. Bülent Urman from American Hospital, Turkey, who is one of the pioneers of IVF in Turkey and in the world. Dr. Urman founded the ART unit of American Hospital of Istanbul in 1996, one of the biggest IVF centers in the country. He is the head of IVF and Women's Health Department of American Hospital, where I have the pleasure of working with. He was the past head and is still faculty of Department of OBGYN of Koç University. He served as the president of the Turkish Society of Reproductive Medicine between 2007 and 2012. He was awarded as one of the 100 most influential physicians in Turkey. As a leader in the field who have witnessed the milestones of IVF, he is going to talk about what is new after 40 years of IVF. Dr. Urman.
Hazır mıyız?
Evet. Hocam sıra sizde. Şimdi canlı yayına alıyoruz sizi.
Ben başlıyor muyum?
Boş ver sen devam et. Misiniz? Bülent Bey,
Efendim?
konuşmaya başlayabilirsiniz.
Can you see the presentation? Am I online right now? Hande?
Evet, başladı.
Okay. Okay. First of all, I would like to express my sincere appreciation to the organizers, especially my friends Özgür and Mustafa, for their kind invitation. What I will be talking about is what is new after 40 years of IVF. So we have been doing IVF for the last 40 some years. What has changed? Are we more successful? Are we more safe? These are the aspects that I will be touching upon. So the questions that I would like to address are: what are the changing demographic trends in IVF? Are we more successful? What are the techniques that have evolved over the years? What impact did the add-ons have on IVF success? And are we better in terms of maternal and fetal safety? So first of all, let's look at the demographics and let's see what has changed. First of all, we have many more IVF centers all around the world. Just look at this map. This is the Turkish map showing all the states of Turkey. And when we first started doing IVF approximately 25 years ago, we were one of the 5 centers in the country, and now we have approximately anywhere between 150 to 200 centers all around Turkey. As you can see on the map, these IVF centers cover most of the country. So number one, we can easily say that patients have more access, and IVF is becoming a more accessible treatment. This is true for all around the world, even in underdeveloped countries. The second changing trend is we are treating patients who are now older than what we have been treating before. This data is from the UK, and as you can see, in 1991, the average age of patients was about 33. Now it is approximately 35. So the patient population appears to be getting older. So this is our data from the American Hospital. So we gathered our data starting from 1996 up to 2018, and the average age increased by about 4 years in our patient population. So we started at a mean age of 32. This is the female age, and now we are all the way up to 36. And this is only part of the story. And as you can see, if you look at the patients that are treated worldwide, and this is data from coming. This data is coming from Europe, encompassing a cumulative 6 million cycles, and the ESHRE data shows that the percentage of patients that are over 40 years of age has also increased now close to about 20%. And the same is reflected in our data from the American Hospital. We can see that the patients who are over 40 years of age, female age, now comprise about 1 in 3 patients presenting to our clinic. Duration of infertility has decreased. So initially we started treating patients who are approximately 8 to 9 years with infertility. Now it has decreased to about 3 to 4 years. And the main reason for this is the treatment is becoming more accessible. The patients are started early on during the course of their infertility. And in my opinion, mostly it is because most of the other treatments that we employ in patients with infertility are not evidence-based, and most of them are not successful. And we are also now treating patients who have many failed cycles, because now patients are going through IVF in centers throughout the world, in centers that in your own country. And look at the patients that we are treating who have more than 3 failed ART attempts. They are approximately 15% of our patient population. So 1 in 6 patients coming to our clinic will have failed IVF attempts with more than 3 or more cycles. The indications have also changed. Initially, we were treating patients with mostly with male factor infertility. That has decreased over the years, interestingly, and now the biggest proportion of patients coming to our clinic are patients who are of older age, and even if they're young, they have a diminished ovarian reserve. So this patient population is especially difficult to treat. And this is also reflected upon the number of oocytes that are collected. Initially, we were collecting anywhere between 10 to 12 oocytes, and that has decreased to about 7 oocytes per patient overall. And this is because of the increasing female age. Stimulation protocols have also changed. Look at the stimulation protocols that we are now employing in our hospital. Most of the patients are going through the stimulation with an antagonist protocol, as opposed to 15 years ago. Most of these patients had a long protocol to stimulate their ovaries. This is also the same data coming from ESHRE, and you can see that the percentage of transfers involving 1 embryo only increased to about 60% in most of the European countries. And in the meantime, more than 3 embryos practically are never being transferred today. So it's either 1 embryo or 2 embryos. And the same is also true for the United States. If you look at the North American data over here, more transfers of a single embryo. You can see that this is elective single embryo transfers, but still in patients who are older, we still transfer, they still transfer more than 2 embryos, especially in patients who are 40 years or older. This is a practice maybe that needs to be challenged and that needs to be addressed. In Turkey, starting from 2010, the legislation has changed and we are allowed to transfer only a single embryo in patients who are less than 35 and no more than 2 embryos for all other patients. If a patient only fails 2 or more cycles, then she's entitled to a double embryo transfer. As you can see, we started with about 4 embryos 25 years back, and now we are down to approximately 1 embryo, 1 to 1.5 embryos. So we do not transfer more than 2 embryos in this country anymore. And we are also transferring embryos now more at the advanced stages of their development. As you can see over here, day 5 transfers have increased, and together cleavage stage embryo transfers now have decreased to a point that is under day 5 transfers. So after all of this, are we more successful when doing IVF? This is again the North American data. As you can see over here, starting from 1991, pregnancy rates were about 7% per cycle. Live birth rates were about 7% per cycle. They have increased to about 22% per cycle. And if you look over here, you can see that there is a significant increase over the years. And down in this graph, you can see that especially fresh cycles appear to have plateaued after the year 2005, and approximately the same pregnancy rate is achieved over here, as opposed to there's an increase and still ongoing increase in the success of frozen embryo transfers. And this is again our data, and this data is encompassing a period of 22 years, and now we are also transferring more and more frozen thawed embryos. And live birth rates have remained quite stable actually in fresh transfers, despite the decrease in the number of embryos, which I will show later with decreasing multiple pregnancy rates. But there is a significant increase, especially after the advent of vitrification, and now frozen embryo transfer success is on par with fresh embryo transfers. This data is coming from Australia, which shows that the live birth rates are gradually increasing and the multiple birth rates, as you can see over here, have significantly decreased, together with a significantly increase now over 80% of all embryo transfers in the Australia-New Zealand region are single embryo transfers. So the techniques have also evolved. We started with basic IVF, then we started this to stimulate the patient. Then we started doing cryopreservation. In patients with advanced age, donor eggs came into play. We did some GIFT, ZIFT, PSD, and things like that. And then one revolution was ICSI, which obviously we are now able to treat male factor patients much more efficiently. And in my opinion, the second revolution in IVF came with the advent of vitrification. So these two factors with better laboratory techniques have increased the success of IVF. So as you can see, with vitrification, now we have a much more higher clinical pregnancy and live birth rate as opposed to slow freezing, and together there's a significantly increased cryosurvival of the embryos that are vitrified. And with vitrification, besides enhancement in cumulative live birth rates per oocyte retrieval cycle, this technique has allowed for systematic application of elective single embryo transfer, because we feel much more confident when we freeze the embryos. It provides the opportunity to perform cycle segmentation. It extends time for embryo evaluation. It permits fertility preservation, egg banking. So all of these became possible with the advent of vitrification and the success of the technique. So in the meantime, what we have added to our armamentarium is the add-ons. So we are now doing hysteroscopies, we are doing PGS, we are using time lapse, we are using endometrial receptivity assays, metabolomics, in vitro activation, PRP, and many others. So this came together with improved sequential media, extensive air filtration, better incubators, and improved cryopreservation techniques, which increased the success of IVF. It's very debatable whether these add-ons actually had an impact on the success of IVF. So if you look at the data coming from SART in patients who are less than 35 years of age, now there's a live birth rate, a cumulative live birth rate of 54.5%. This is a very good success rate. But where we fail is patients who are over the age of 40 years. So as you can see, the success rate in these patients are very low. However, if you find a euploid blastocyst and if you transfer that blastocyst to the patient, it appears that the pregnancy rate and the live birth rate is independent of maternal age. But the problem is finding that euploid blastocyst. As you can see here, in patients who are over the age of 40, you need many, many oocytes eventually to end up with 1 or 2 euploid blastocysts. In the patient at the age of 42, to get only 2 euploid blastocysts, you will have to start with 20 metaphase 2 oocytes collected for that patient. And this is most of the time unrealistic, and it's only very few patients that would benefit from this technique. You can see here that the number of mature oocytes retrieved according to age going down. This is our data from about 15,000 OPU cycles, and the number of eggs, as you can see, have significantly decreased. So among these patients, it's very difficult to find a euploid blastocyst. This is also the data published approximately 6 years ago, showing that the number of blastocysts that are able to be biopsied, especially in patients over 40 years of age, in average is about 2 blastocysts. So you are ending up with 1 or 2 blastocysts that you are able to biopsy. And this age group is the age group apparently who will benefit the most if you do pre-implantation genetic screening. And unfortunately, randomized trials did not show a significant impact of pre-implantation genetic screening for aneuploidy on IVF success rates. This is the European multi-center study. The biopsy of the embryo was done on the polar bodies, and which is one aspect of the study that may be criticized. But eventually they showed that in patients who underwent the biopsy and no biopsy, cumulative live birth rates were exactly the same. And coming from a group that is a big proponent of PGT-A, this multi-center randomized study also showed that the live birth rates did not significantly improve in women between 25 to 40 years of age, either analyzed per embryo transfer or per intention to treat. So we are coming back in a full circle, and now we are questioning the efficacy of pre-implantation genetic screening for aneuploidy, which in my opinion is one of the add-ons probably we are putting on the shoulders of the patients unnecessarily. So there are many other add-ons, and I think most of them are getting out of hand because the patients obviously are requesting from their physicians some different form of treatment, but the physician is left with nothing else to offer to these patients. Hysteroscopy, for example, subjected to a randomized clinical trial in patients who never had IVF prior to the first cycle, showed no difference in pregnancy rates in patients who had hysteroscopy or who had immediate IVF, and also in patients who had prior failed cycles. You can see that rates per participant, or in patients receiving a top quality embryo, in patients who had a hysteroscopy and who didn't have a hysteroscopy, the pregnancy rates were exactly the same. So what happened with maternal and fetal safety? As you can see, that two major safety concerns in patients undergoing IVF were OHSS and multiple pregnancy, and we have both successfully addressed these problems. Now we are seeing very, very few hyperstimulation syndromes with the advent of the agonist trigger in patients who are overstimulated. And I think we have successfully addressed the concern of multiple pregnancy, especially in younger patients, with the practice of transferring fewer embryos. Maybe single embryo transfer, especially after the success of vitrification, should be mandatory across the board to decrease multiple pregnancy rate, which appears to have not decreased in patients who are older, let's say over the age of 38. And are we more safe to the baby, like in terms of preterm birth, low birth weight, SGA, LGA, stillbirth and perinatal deaths, and long-term consequences or outcomes when the baby becomes an adult, like cancer risk, neurodevelopmental health, cardiometabolic health, growth and reproductive function, which may all be affected by epigenetic effects of the IVF procedure that we perform. I think we should keep a handle on all of these issues and address these as they come across, because these are the issues that need to be solved, especially in the future. So after 4 years of IVF, we can say that the female age has increased, the number of collected oocytes has decreased, pregnancy and delivery rates have increased. The impact of add-ons, I think, is uncertain, and I don't think they have a significant impact on the success of IVF. Personally, I'm not a big believer in add-ons, and I think they are they actually create the perfect environment for patient exploitation. Multiple pregnancy rate have decreased. It's safer for the mother due to avoidance of OHSS and multiple pregnancy rates. And I don't think IVF is any safer for the fetus, maybe only in the aspect of decreased multiple pregnancy rates and preterm births, but not in terms of other epigenetic defects and other abnormalities. I think still ART is still more art than science. And in my opinion, we're still over-treating some of the patients, and especially with the add-ons, we are increasing avoidable harm and increasing healthcare costs. The novelty and apparent sophistication of the new technologies that we introduce into IVF unfortunately take precedence over proof of their effectiveness and safety. So still the balance of IVF is towards tradition, opinion, and lure of new technology. And I think in the next 40 years, or maybe hopefully before that, we should have more data, and we should actually practice more evidence-based IVF for the sake of our patients. Thank you very much.
Thank you very much, Dr. Roman. Our second speaker is Michael Bombor from Women's University Hospital, Bern, Switzerland. He is the head of Division of Gynecologic Endocrinology and Reproductive Medicine. Regarding fertility preservation, he has established the German-speaking network of fertility preservation, FertiProtect, in 2006. Furthermore, he had founded the ESHRED Task Force on Fertility Preservation, has co-founded in ESHRED's Special Interest Group Fertility Preservation, and he is board member and nominated vice president of ISFP. He is also president of Swiss Society of Reproductive Medicine. His topic is fertility preservation, a global view with current guidelines of international societies. We may have a few seconds delay because of the international connection, and we will take the questions at the end of this session.
Your time. I'm live. Hello? Can you hear me?
Yes, we can hear you.
Okay, can you hear me?
Yes.
Yes, we can hear you, Dr. Wolf.
Okay, let me just share the presentation.
You can begin, please.
Okay. Okay, so you can hear me and I can start my presentation. It's down here. Okay. Okay, thank you very much. I start my presentation. Well, thank you very much for organizing this fantastic meeting. Technically, it's a bit difficult, we know, but I'm amazed what kind of speakers you had invited. I was asked to talk about fertility preservation, the global view with current guidelines of international societies. When I started preparing this presentation, I realized it's pretty difficult to give a global view and to go through all these different guidelines. That's the reason why I decided to make it a little bit different. What I will do is I will just go very quickly and very roughly through the main techniques which are available and when these techniques should be offered. And then, knowing this, having all this evidence, we go to the question what it is offered worldwide and what kind of guidelines and recommendations we have. So when you look at GnRH agonists, we do know that we have a short-term efficacy of reducing the POI risk in breast cancer. So only short-term efficacy of POI in breast cancer, nothing else. We do know that we have a little bit data regarding the long-term efficacy in breast cancer, but only a very small study. And we do know that we have no data regarding different cancer diseases. So this is the evidence we have, and we will see what the guidelines tell us. What else we have is a little bit of, what is that? Can you see me? What else we have is a little bit of data regarding pregnancies, after giving GnRH agonists, but these data are pretty poor. Regarding freezing of oocytes, we know that this is an established procedure. We can start anytime we want. We have a random start stimulation protocol. It works very easy. And what else we also know is the success rates of, let's say, around 30% in general, and age dependent in young women of about 40%, in older women of 30%. So again, that's the evidence. It's established and we have a success rate quite nice, but lower in older women. Let's take the last thing to see what the current evidence is. The current evidence regarding ovarian tissue is that removal and freezing of tissue is easy. We can take 50% of an ovary out, or we can take 50% of a whole ovary out. So this is an established procedure regarding the evidence as far as I think, but we do not still know what is the best technique to transplant the tissue, either within the peritoneum, or that's what it looks like 12 months later, the ectopic ovary, or into the ovary, or maybe onto the ovary by laparoscopy, and that's what it looks like 12 months later. So regarding transplantation, it is not established. And let's see later on what the guidelines tell us. So the success rate in ovarian tissue transplantation is, according to the studies we have, current evidence is 25%. We know that in some centers, if you have super highly specialized centers like Israel, Belgium, US, we might have a success rate of 40%, which indeed is similar to the one of oocytes. So we have similar success rates when you look at the very recent current literature. But of course, it's age dependent. In older women, the success rate is much lower. In younger, it's higher. The same as in oocytes. When we have guidelines, guidelines should tell us what kind of techniques we should perform, but guidelines should also tell us when we should do these techniques, who should be counseled. And when you look at these information, at these studies, then here you can see the number of patients getting a transfer after freezing of oocytes. It's only 6%. The number of patients getting a transplantation after tissue freezing is only 3%. And the number of using a sperm, it's 8%. So it's very low. It seems to be a little bit like an overtreatment, what guidelines should avoid. When you even go into further detail and you see how many patients had given birth to a baby after freezing of oocytes, it's only 2%. So 100 women froze oocyte, 2 women got a baby. In tissue, it is even 0.8%. 100 women froze tissue, 0.8% got a baby. Sperm similar. We do have new data from the ESHRE that this number might go up to 11% in UK. And this number of tissue might go up to 2%, but it's still very low and we are frightened of having an overtreatment. And the question is, do the guidelines guide us to avoid overtreatment? Guidelines should tell us who needs to be treated and who needs to be offered these treatments. And we can have a very liberal attitude. They should be offered to anybody. Risk of overtreatment. We could have a very restrictive attitude. They should be offered only to those with a very high risk of infertility. These are the Edinburgh criteria, with a risk of undertreatment. Or the guidelines could have a very practical attitude. They should be offered to those who have a relevant risk of treatment-induced infertility. Not too many, not to a low number of patients. And these guidelines should also include who needs to be treated, which age. This is a recommendation of the network FERTIProtect, that only patients should be counseled and treated who will probably survive, in which later pregnancy is compatible with the health of the women, and, as I personally think, women who have a risk, a moderate risk of getting infertility, chemotherapy-induced infertility of, let's say, more than 20%. By the way, this very newly published book covers about 80% of the diseases for which patients are counseled. And this book gives specific details in which cases these women and men should be counseled. So in which cases the risk is at least 20%. So it's a good guideline regarding patients having a risk of at least 20%. So this is a basic idea, is a basic concept of creating guidelines, as far as I think, to give a real guide. Guidelines are supposed to cover the situation in Europe, worldwide, etc. But let's see what happened globally. There is only very few data around. It doesn't make sense to make a kind of heat map to see what is going on where. But what Teresa Woodruff did here, just published in 2020, they sent a survey to different centers worldwide to see what kind of obstacles these countries have to install fertility preservation. And when you look at, let's say, Denmark is a good reference center for a very liberal country, and you see it's empty. So there are almost no obstacles. But if you look at Egypt, you have a lot of problems: lack of insurance, financial burden, lack of providers, cultural and religious barriers. So guidelines could or should, or maybe they should not, consider all these different problems we have worldwide. And you see there can be tremendous problems like cultural and religious barriers. What Teresa Woodruff also did, they sent this survey to all these different centers worldwide, and 14 of the 23 centers who responded stated that some techniques were not offered due to cultural and legal reasons, confirming what I just said, that this is a big issue. Let's look at oocyte freezing. A huge number of centers actually offered oocyte freezing in adolescents, in adult patients. Amazingly, a large number of centers also offered ovarian tissue freezing. I assume these are selected centers, but the majority of centers apparently also offered this. But other techniques like oocyte donation, sperm donation, egg donation, etc., the number of centers were very low, and this can be part of a guideline, but it cannot be a part of a guideline. If the Americans who offer oocyte donation include this in their guideline, this guideline is, for example, useless for Germans because we are not allowed to oocyte donation. Based on or due to these different attitudes, these different cultures, the spectrum of techniques offered worldwide is quite different. When we look at this German, Switzerland, Austria FERTIProtect network data, then you see that about 1/3 of women, adults, got an ovarian stimulation with oocyte freezing, 1/3 got tissue freezing, 1/3 got GnRH agonists. EV Spain, it was similar, 50% oocytes, 50% tissue. But when you look at the UK, the numbers are totally different, and you have a tissue freezing of 1 to 5%. They are almost only doing oocyte and embryos. So there is a tremendous heterogeneity in techniques performed worldwide and also in Europe. We know that Europe is a hotspot for ovarian tissue. In this paper from 2018, in which all the transplantations were mentioned, and you see that the main countries are Denmark, Germany, Austria, Switzerland, Israel, Spain, Sweden. So we do know that Europe is a hotspot for tissue transplantation, as shown here as well. FERTIProtect numbers going up. But another tremendously large country, China, they just published, one author is member of FERTIProtect, they just published the first 10 transplantations without a baby. So again, there's a tremendous heterogeneity regarding the different techniques worldwide. So what do the guidelines recommend? Let's see what the guidelines recommend. There are these different guidelines here. There are these 3 different guidelines which I picked out. The American guideline from 2019, written by reproductive physicians. The German, Austrian, Switzerland guideline from 2018, written by reproductive physicians and oncologists. And the ESMO guideline, which is just in place more from the oncology point of view. And let's look at the different techniques. Oocyte freezing, we said, current evidence says it's established. And yes, the guideline says it is established. Ovarian tissue freezing, The guideline says, well, American, it's not longer experimental. The Germans say it is an established procedure. Here the ESMO says it's appropriate. It's a fine difference. It's a little bit of difference of the wording, but more or less it is established regarding these huge guidelines. By the way, the ESHRE guideline is not finished yet. That's why it's not included. But now look at the GnRH agonists. GnRH agonists saying, the Americans say it may be offered to breast cancer patients, potentially other cancers. So they stating breast cancer and potentially other cancers, but we don't have evidence for other cancers. The Germans say it can be offered. And the ESMO says it should be considered in breast cancer. That's exactly what the evidence says. And it can be discussed in other malignancies. So here regarding GnRH agonist, these guidelines, which are 1 to 2 years old, and if a guideline is 1 to 2 years old, the contents are already 2 to 3 years old, are not up to date. The only one which is really up to date is a very, very recent one. And who should be counseled? What do the guidelines say? I just said we need to avoid undertreatment, overtreatment. But let's see what the Americans say. They say everybody needs to be counseled. Maximum age not specified. So even women at the age of 44 should be counseled with a far too low chance to get a pregnancy later on. The Germans say any patient in reproductive age, there is no limitation. It is the spectrum of patient is far too large. And the American, what the European oncologists, what do they say? Any patient at reproductive age, again, there's no limitation, which does not really reflect the evidence. And what they even say in addition to that, in any patient with any type and stage of the disease. So even patients with a very severe disease, which does not really make sense. So the conclusion, fertility preservation techniques vary across the world, as you could see. Differences are due to legal, cultural, and economic reasons, and also religious reasons, what we don't really think about. The main procedures such as GnRH agonist freezing of oocytes and ovarian tissue is now accepted by most societies. Well done. But further studies and guidelines are needed to sharpen indications to avoid over and under treatment. I think the guidelines here are pretty much weak, too weak, because we need better guidance to what we should recommend our patients. So further studies are needed to improve the available techniques to achieve high success rates around the world. Thank you.
Thank you, Dr. Bombov. Our third speaker is Dr. Emir Arav from Israel. Dr. Arav is the leading scientist in the field of cryobiology and reproduction. He holds a PhD degree in neuroscience, physiology, and biomedical engineering. He founded Galcore and Core Dynamics, all of which specialized in the field of cryobiology and were based on Dr. Arav's patents. He filed over 60 patents and is the recipient of merit prizes from basic and applied research. His lecture is Fertility Preservation and Cryobiology in the 21st Century, Glimpse from the Future. Dr. Arav?
Hazırız.
Okay, that's your
Hello.
turn, Dr. Errol.
Okay. So can I load the presentation? Hello? Oh, this is not the beginning. Okay. I don't see myself. Hello, hello. Can you hear me?
Yes, we can hear you, Amir.
Okay, so I can start. Can I start?
Well, I'm saying you can start, but I don't know if I'm in charge, Amir.
Ah, yeah, Evelyn.
Evelyn.
I said, wow, what is this
Hi, Amir.
Scottish
It's Richard Anthony.
accent?
I'm listening as well, so you go ahead, I think.
Yeah.
Yeah. Okay.
You've got your Edinburgh.
If you both listen, I can start. Okay.
You've got your Edinburgh fan club here, so that's okay.
But can you see me, because I don't see myself?
Yeah, we can see you. You're sort of messing around with the keyboard now.
Yeah, but why don't see myself? I don't understand it.
You don't need to see yourself. Just go on.
Okay. Okay. So I'm waiting to the organizer to tell me that this is really crazy. Let's see. Can I start? I'm sending them an email. How are you, Evelyn?
Yeah, good.
Yes?
Good. Yeah.
How is the situation in Scotland? Is it okay now, safe, and what?
No. We're still more or less in lockdown.
Really?
Yeah.
Wow.
Yeah, we're very limited on who we can see. I mean, I've not even seen Richard for about, what, 6 months, Richard, huh?
Yeah.
Yeah, just Zoom.
Yeah, it's all Zoom meetings.
Only Zoom meetings. It's making
Yeah.
me crazy. It's making me crazy.
I know. Everything's online. And then we start our academic year next week, and everything is by online teaching and meetings. So
Really? So
yeah.
how, and PhD, how can
It's a good
student, how can you do experiment online?
I know. Well, we do, but it's very much reduced. Very much.
Slaughterhouse and things like that are possible? I don't know.
Yeah, it's difficult.
Very difficult. Wow. Amazing. Amazing. Well, let's hope there is some evidence now for T-cell memory, which might answer some of the questions. Maybe we'll see something new.
Dr. Errol?
Hello?
Hi.
Hello.
That's your turn.
Okay.
You can begin now. Thank you so much.
But can you see me? I don't see myself. I don't know why.
We can see you.
Okay. So I'll just go ahead, right?
Right.
Okay. Okay. First of all, thank you. I would like to thank the organization for this kind invitation. My name is Amir Arav. I'm from Tel Aviv, working for FertiLitySafe. And my topic is fertility preservation and cryobiology in the 21st century, a glimpse from or to the future. And slide. Okay, yeah, so I decided to put this slide first, which can be also the last slide, just to show you what I'm going to talk for the next future, fertility preservation, probably the next 20, 30 years from now. It will be automation and lyophilization. I think these two things will come possible. Automation, what do I mean by automation? After sperm and oocyte and tissue collection, we can have automation in oocytes, sperm and tissue vitrification automatically, as I'm going to show you next. If we need to develop an embryo, we'll have a device that will do automatic IVF, in vitro culture, and blastocyst vitrification, all in the same device. And then this device can do also automatic warming before we'll do the embryo transfer and getting pregnancy. So in the area of lyophilization, I think that it will be possible probably first to do sperm freeze drying, and then we'll move into oocytes and embryo V-drying, which is a combination between vitrification and drying. And probably also it will be possible to do some tissue lyophilization, storing at room temperature or at 4 degrees centigrade, as I'm going to show, adding water or some hydration solution, rehydration solution, before we do the embryo transfer, or using the oocytes and sperm for the IVF. So before looking at the next 30 years, let's see what's happened 35 years ago. So 35 years ago, Bill Rall and Greg Fay showed the first successful vitrification of mouse embryos. And this is here on the right, Bill Rall telling me, I'm here on the other side of the table, Andrea Van Stertigem and Anna Ferraretti telling us about the vitrification. I was amazed, and I decided that I'm going to do some research in this area. And it took me a few years to develop what I call the minimum drop size technique, which is a small volume of less than 0.1 microliter, placing on a cryocarrier and vitrified in liquid nitrogen. So this became the method of choice for oocyte vitrification and also for embryo vitrification. And there are many different cryocarrier devices like CryoTop, OPS, Cryotech, Cryolock, CBS, Vitrifit. Most of them using different solution technique or different cooling and warming protocol. And there is a lot of variability, which should be standardized by doing automation. So if we look at automation, we need to solve different needs, especially for oocytes vitrification. The first one is the cooling and warming rate. It should be rapid. It should be rapid for two reasons. The first one is for vitrification, but the second, which is even more important for the oocytes, is the chilling injury. So we have to overcome chilling injury, and we have to do it rapidly by rapid cooling to liquid nitrogen temperature. As I said, it's working because of the small volume of less than 0.1 microliter, what we call the minimum drop size technique, and it should be still done with the same way. It has to be easy to operate and to store the liquid nitrogen, something which does not take a lot of storing space, like straws, for example. It has to be all automatic. That means from the preparation of the equilibration solution, the vitrification solution, the plunging into liquid nitrogen, and the warming steps, everything have to be automatic. The mechanical damage should be avoided because these cells are very sensitive to mechanical damage at the state of preparation. And they have to be, everything have to be a short time of procedure, of course. Now, because we need a rapid cooling rate, especially for all sites, we need to operate with open system, which means that direct transfer into liquid nitrogen. And I'll show you some solution that we have also in this area. So what we proposed is a small capsule called EVIT that you can see here, which sit in the tip of the straw. And it have many pores, square pores of 50 micron each. And this is a bovine oocyte here, and this is the pores. So now you load first the oocytes inside the straw, then you plug the capsule, as I'm going to show you in this video. So you just push and plug the capsule. And now you are ready to go through the solution manually or using the device. Now, the whole principle, the whole mechanism is that the solution that we are changing will penetrate through the mesh, through the capsule by capillarity, and the oocytes or the embryos will sink to the new solution by gravity. So this is Sarah, the automatic device that's making it. And this is my daughter, her name is Ayala. And she was doing one of the first vitrification of oocyte just by plunging the bottom. What we have inside Sarah, we have 6 straws of quarter cc straw for oocytes and embryos, or we have larger straws for tissue, for testicular tissue and for ovarian tissue. So we first select the procedure. We select the time in each one of the steps, and then sorry, this is sorry for music. And then we will have all the steps that we selected, depending on the protocol, if it's for oocytes or embryos or tissue. And the straws will go to a different solution, which is also temperature controlled and environment controlled. Then I'll move to the last part, which should be here. In the last part, the straws or all the liquid in the straw will be drained on absorbing paper, sterile paper. And then after all the solution are drained, the straws will be plugged into this liquid nitrogen dewar, which is sitting here on the green. And wait, and then it will stop and wait until the embryologist will take it to the liquid nitrogen container. Right in the liquid nitrogen. Okay. So results, we had a very high survival with mice, oocytes, and embryos, both in the HL stage and blastocyst stage, with good hatching, survival and hatching for blastocyst. And but the most important results came from ovine embryos at the blastocyst stage, where a colleague of mine, Sergio Leda, did a comparative study between 2-step exposure to a 6-step exposure, as you can see here. And very surprisingly saw that, first of all, day 7, are better than day 6 in terms of vitrification of blastocyst. But what was interesting to see was that the multiple stage of multi-step stage of exposure was better than the 2-step. And this was not only 24 hours post-warming in cultures, so it's also including hatching, but also the apoptotic cells. As you can see here, the dynamic system, which is the 6 steps, had almost no apoptotic cells comparable to control, while the 2-step had more apoptotic cells in the blastocyst stage. So, in the veterinary field, it will be very important to do direct transfer of vitrified embryos, which means going from the liquid nitrogen into different steps of solution to dilute the embryos from the vitrification solution, and then to transfer to the uterus of the animal without to take the embryos out from the straws. So this is what we call direct transfer, and this is very important in the veterinary field. The question is if it will be possible also in human. A physician, a doctor in his clinic will have a liquid nitrogen container with embryos, with blastocyst, 1 blastocyst for per straw, and then he will take out the straw, move it or manually into the different solution, or by the device that I just show you, and then incubate it for about 2 hours. Look at the embryos if they re-expanded and they look okay, and then adapt it to embryo transfer catheter and transfer the embryos to the uterus. Recently, we found out that this capsule is also very good and for sperm selection. So the idea was that if we can do sperm selection and put and place oocyte inside, and we did it with the bovine, placing oocyte inside straw, and make let the sperm move through the capsule to inseminate the oocyte, and then culture the oocyte or the fertilized egg for 5 days in the incubator inside the straw together with the straw, and then this straw goes into vitrification procedure and to liquid nitrogen or warming, everything in the same, everything without to take it out from the straw. So we looked at it, and it looks like it possible. Another possibility is to do tissue vitrification using the device, and this is ovine prepuberal testicular tissue that was vitrified with the EVIT, with the straw, and we found that we both had a good plasma membrane integrity following the vitrification, and also expression of all the genes that are comparable to fresh control. We did also a pilot study in Yale with human ovarian tissue vitrified as a control, conventional vitrification technique, or with the EVIT, with the straw, and we found no difference between the two techniques. Also, as I said before, we need a direct transfer of the straw to liquid nitrogen, which means that we need sterile liquid air, sterile liquid nitrogen or sterile liquid air. So we produce this device, it's called Claire, which produces in 10 minutes, it produces about 200 milliliters of liquid air, as I'm going to show you now. And this liquid air has the same temperature like liquid nitrogen, but it's completely sterile. and you can use it both for your cryocarrier devices that you use, Cryotop or Cryolock or whatever, and also for the EVIT automatically vitrification. So we are not the only one in the automatic area of vitrification. The Genea produce a device called Gavi, which also prepare the vitrification solution for vitrification, but still need the manual plunging into liquid nitrogen. And there is a promise from ESCO to present probably in few months from now the new vitrification device for oocytes and embryos. Now, another possibility for, as I said in the beginning, is lyophilization. And lyophilization will allow you to store at room temperature at 4 degrees centigrade and to get rid of all the liquid nitrogen, which is risky, costly, and make a lot of problems, as we know, as we just heard what's happened last year in the United States. So this is how it should look like next on the shelf, like we preserved many pharmaceutical drugs and medicine. In nature, this animal called tardigrade can dry itself to less than 2% water content, and it can stay at the dry state for 10 years. We can freeze it to absolute zero and it's survive, or warm it to 151 degrees centigrade and it will survive, and even irradiate it to 1,000 times the killing level, and if it's in the dry state, it will survive. So we developed a device called Daria, and this is a device that stays in liquid nitrogen. It's a very small, like a canister in the size, and you can do something like 4 vials together for the freeze drying or vit drying of sperm, oocyte, and stem cells. So this is how dry human sperm looks like at the dry state, and we found that they maintain 80% or more DNA integrity, and this was published. And very recently in New York, just before the corona started, I was in New York, and we did it with John Zhang laboratory, fertilization ICSI of dried human sperm injected into donor oocytes, and we found that 5 of the 8 had a normal 2PN, and from these 5, 3 developed to the blastocyst stage, and we did PGD on these embryos, and they look normal. There were 3 female embryos, and look absolutely normal. And this was the first human embryos, blastocysts, that were developed from dried human sperm. And it was selected for the oral presentation in the SRM, the next coming SRM. Finally, I want to tell you something about drying stem cells, which was also our topic for several years. And we did umbilical cord blood, mononuclear cells from umbilical cord blood. We freeze dry them and produce the same percentage of CD34 and high viability, basically no difference, almost no difference than fresh control after freeze drying and rehydration. But the most important is colony formation unit, and we produce colonies out from this freeze-dried stem cells that produce colonies of erythrocyte, granulocyte, macrophage, and so on. And this work was repeated 10 years ago by John Carpenter, that also did the umbilical cord blood and find colonies after 6 months storage at room temperature. I want to end with thanks to the people working with me, Pasquale Patrizio from Yale University and Paolo Levisetti from Humanitas Milano, Lino Loi from Teramo University, Sergio Leda from Sassari University, Italy, Zvika Roth and Elisa from the Hebrew University, Jerusalem, and Stoyana Alexandrova from the New Hope Fertility, New York, and my group, Fertile Safe. Thank you very much.
Thank you, Dr. Arau. We have some questions to you. First of all, I want to ask that patients seeking fertility preservation due to cancer treatments, as we all know, it takes long time to see the efficacy of cryopreservation approach. What is your opinion? Do you hear me? Can you hear me? Dr. Arau? Thank you very much, Dr. Arau. Hello.
No, I can't. Hello? Hello?
Hello,
Can't
there's
hear
a
you.
question for you. Can you hear us?
Hello?
Hello.
Thank you very much, Dr. Arau, for your nice presentation.
Hello?
We are starting our questions and answers.
Can you hear me?
Yes, we can
I
hear you,
can't
Dr.
hear the
Arau.
question, if there is a question. Maybe in the chat.
And we have 2 questions for you. Can you hear us?
Please wait a little bit. No, this is not now.
Oh. Okay. We all thank our 3 speakers for this section. We will be together with the next section. We have half an hour break. 15 minutes break. Okay.
again, it's going very well. Today's sessions are going very well, and we have more than 300 listeners from all over the world. We have eight speakers and from 12 speakers from 8 different countries, and so sometimes we have connection problems. Please excuse us for this reason. And on the right upper corner of your screen, there is a send question button. If you have questions, we are going to take the questions after the session, and please send from this send question button all of your questions. And now our first speaker is Richard Anderson for this session. He's from University of Edinburgh, Scotland. He was appointed to Chair of Clinical Reproductive Science at the university in 2005. He has established a group investigating female reproductive lifespan with laboratory and clinical aspects related to adverse effects of cancer treatment on fertility. He has also conducted clinical studies on kisspeptin and norokinin B in human reproductive function in men and women. He is past coordinator of the ESHRE Special Interest Group in Fertility Preservation and is a member of the HFEA Scientific and Clinical Advances Advisory Committee and the ESHRE Executive Committee. His lecture is 20 years of fertility preservation after 40 years of IVF. Dr. Anderson?
Hello, good evening. Welcome everybody and virtually. It's Richard Anderson here. It's a pleasure to be speaking to you, and I hope the rest of the conference is a great success. Thank you for the introduction. So I was going to talk today about the past of fertility preservation and what we can learn from it. And indeed, I hope I'll emphasize to you that a lot of the issues that have been raised throughout are still thorny issues in this field. But it has come on a huge long way, and as I'm sure Michael von Wolf explained, we now have a number of international guidelines that help promote this whole field. There's really been such an explosion into current practice from a research background in really a very short period of time. So in the United Kingdom, we have the National Institute for Clinical Excellence, which determines clinical practice in the UK. And this first brought fertility preservation into mainline clinical practice in the UK now over a decade ago. And at the same time, and on the left here, you can see a guideline that was produced by the Scottish Intercollegiate Guideline Network looking at childhood cancer, and that also highlighted the need to consider fertility preservation. So just within the UK now for over a decade, we've had important guidance trying to shape practice and promote it for patients with cancer. More internationally, we have the very influential ASCO guideline that's been led by Kutluk Oktay for a number of years and has been updated on several occasions since then. And indeed, things have moved on to perhaps the next level with a representation represented in this paper, which is a harmonization of different guidelines. So not only do we have guidelines, we have harmonization documents that tend to try to bring them together and to promote best practice. And shortly in Europe, we're very going to have the European Society for Medical Oncology's guideline on fertility preservation for men and women with cancer that is now in press in the journal Annals of Oncology. And the ESRA, the European Society for Human Reproduction and Embryology, that guideline on female fertility preservation, which I've had the honor of chairing, That, I hope, will be finally signed off in the next few weeks, and so will be published by the end of this month. So we have a plethora of robust, very robustly evidence-based documents on which to guide our practice. So that's where we really currently are, but actually this builds on a very long historical background of fertility preservation attempts. And this is a slide showing data from a review by David Nugent and Roger Gosden from the end of the last century, in fact, highlighting some of the very early studies going back 120, 130 years even, looking at trying to transplant ovarian tissue and the variable success. And you can see that these very early studies did apparently report success, remarkable pregnancies perhaps, and some of them were quite large. So you have studies from Germany and from France with over 100 and over 200 experiments, cases reported with some success with menstruation in the one and good results in inverted commas in the other. So there's been a very long tradition of trying to transplant ovarian tissue to achieve a subsequent pregnancy. And this really came into sharper focus in perhaps the early 1990s with the advent of cryopreservation of tissue. And this paper, I think, by John Carroll and Roger Gosden was quite influential in perhaps shaping Roger Gosden's ideas on the subject, that he could transplant frozen thawed follicles and achieve success from that. And that led on to further work that Roger went on to do in rodent models, looking at transplantation of ovaries and indeed whole reproductive tracts, ovaries and uterus together. And at the time, Roger was working in Edinburgh. He was a professor of reproductive biology. And I think one of the defining events that happened then was deciding to get together with my own personal clinical mentor, David Baird, a clinician in reproductive medicine in Edinburgh, professor of obstetrics and gynecology, to get together to try and develop this towards more of a clinical perspective. And Roger therefore brought some of his brilliant ideas to it, and what David really brought to the party was the fact that he was using sheep in his experiments to look at ovarian function. And they have huge advantages compared to rodents, although of course they have some cost disadvantages, but they are a large size, and therefore you can do repeated blood sampling experiments, you can do surgical procedures very comparable to what you could do in a human. And indeed at the time, one of the models that David was working on was an ovarian transplant into the neck, where it was revascularized, and therefore you had access to the ovarian vein, and you could therefore measure the hormones coming out of the ovary. So this fantastic collaboration led to the development of ovarian cortex autotransplantation and cryopreservation using this sheep model. And this picture shows an oophorectomy here, and you can see the rather unusual shaped uterus that the sheep has. And then they dissected off the cortex of the ovary and then replaced it back, just very simply sewing it on with a couple of silk sutures onto the ovarian pedicle, both fresh and frozen. And indeed, these experiments were remarkably successful in showing restoration of some ovarian activity. So here is a couple of hormone profiles from an individual animal showing a period of anovulation with the progesterone in red and some elevated FSH levels, consistent with the equivalent of the menopause in women, followed by repeated estrus, repeated cyclical progesterone elevations. So all the animals where he was able to do this showed some cyclical activity, and they were able to show that there was preservation and function of ovarian follicles in all the fresh and very nearly all the frozen grafts. So an endocrine response here with ovulation in a cyclical manner. And if you look at the data over a bigger picture, and this is a compilation, obviously, of a number of animals, you can see what's going on here. So you have the strip replaced, you have a period of before it really restores activity, and then again you have this period of time with cyclical progesterone activity for many months going on. And at the same time, you have a decrease of, to some extent, in FSH levels from here down to here, although they remain elevated compared to normal animals. And of course, being the sheep, This is a seasonal breeder, so you have this summer hiatus of activity, and then in the autumn, again, this restoration of ovarian activity. So long-term ovarian function restoration demonstrated in this model. But as we still grapple with, the FSH levels remain slightly high, and indicating a reduced ovarian reserve, perhaps a perimenopausal situation. And as I say, that remains an ongoing issue. So what they were also able to demonstrate from that, looking at the survival issue, is that actually it's the post-graft survival that's most important, not the freezing aspects. So here we have control fresh and frozen numbers of follicles, and you can see that they're very similar, whether fresh or frozen after a period of time after grafting. So it's the revascularization process that is thought to be so important in the survival of these residual approximately 30% of follicles. And I think that's something that we really haven't got a lot further with clinically in this field of how to optimize that. And there's been work done with different freezing mechanisms, with using pro-VAGF activity compounds to try and promote that, all with some effect, but still the lion's share of the loss really remains a problem. And they were able to demonstrate that endocrinologically. Nowadays, of course, we would use AMH probably to investigate this, but they were using inhibin A as a marker of antral follicle growth. And you can see this substantial loss of inhibin concentrations in these animals during the course of revascularization and thereafter. But it was successful in terms of restoring fertility, and this is, I think, possibly the very first sheep that was born, lamb that was born following this, and importantly, following natural conception. And I think this is one of the key areas in the field, is that at the moment, it remains the case that most of the children who've been born from this, not a large proportion, a great excess, but more than half the children born from this have been born from natural conception. And I think clinically and from the patient's perspective, that's a really important aspect of this whole field. So I think if you read those papers that Gosden and Beds and colleagues published around then, there's an awful lot of ideas there that are still very much hold true today, and are still issues in the field. So they showed, as I say, this autotransplantation allows long-term ovarian function and natural conception. They showed that a high proportion of follicles are lost, and there is this increased activation of follicles that seems to be a feature of this, with more, a lack of retardation of follicle growth. And therefore, this excess recruitment of primordial follicles is suggestive of removal of an inhibitory mechanism, which may indeed be a factor like AMH, which normally operates in the intact ovary and is lost. And of course, I'm sure we'll be hearing more about that from Dror Maro tomorrow, talking about trying to protect the ovary, and indeed trying to slow down this overactive recruitment would probably enhance the duration of life of these grafts. So this has, of course, now become very much an established field. As Michael von Wolf said earlier today, this is now becoming more established therapy around the world. And this is a lovely review by Jacques Denet and Mary-Madeleine Dolmans, published a couple of years ago, showing this exponential increase in the number of births reported around the world from ovarian cryopreservation. And as they say, many experts now accepting that this is a valid and effective technique rather than an experimental approach. But I think it remains the case that actually the success rates with this in the larger series that have been published show that it's in the order of 25 to perhaps a little over 30% of women will achieve a successful pregnancy through this. So although they claim it's effective, actually the majority of women who undergo this are still not having the baby that they desire, and therefore there's still a long way to go before we can really use this to its optimal potential, I think. The other aspect that's raised in this review is the need to consider which patients might be most appropriate for this, and they highlight these three selection criteria. related to age, and we're now starting to see some data on that, although a precise cutoff is going to be debated, and there are a lot of people who think that it should be older than 35, but yet there remain very few pregnancies in women in that age group. Oncologically, there's a need for a realistic chance of survival, and there's also the question of how much risk is appropriate for women to be up against before an invasive procedure like this, with a perhaps still fairly modest success rate, is appropriate. And there's a lot of debate and discussion as to what that figure should be. But I think that there needs to be some agreement within individual countries, depending on the health service that you work in. That's going to be variable according to how your health service is organized. So if we move on from ovarian tissue to thinking about where things have moved on for oocytes, and indeed, of course, worldwide, this is far more important numerically as a form of fertility preservation than ovarian tissue. And indeed, we've seen enormous advances in this. Anna Cobo, again, of course, will be speaking later in this meeting, and her and other groups have really pioneered the use of vitrification to make frozen oocytes basically almost as good as fresh. And in this lovely study that they did now a dozen years ago, you can see that the survival of vitrified oocytes was approaching 97%, with very good implantation rates for the blastocysts that they achieved. But I think it's important in this regard to consider that perhaps not every clinic can match these success rates, because expertise will vary. And I think it's really not appropriate for clinics just to quote the results from the very best field as results like this. And some local data are going to be really important for the true discussion with patients as to what really they can expect rather than what they might expect in the best possible hands. And Anna and colleagues have recently published some very interesting data on that I'll come to in a moment, that really compares the issue of elective or non-medical freezing of oocytes versus for fertility preservation. Because this has really been a growth area over the recent decade or so. And on the left here, you see data from the UK, from the HFEA, only going up to 2016. That's the most recent data available. But you can see this dramatic rise in the number of egg freezing cycles that have happened. And I'm sure you can imagine that will have gone up steeply since 2016. And there is, of course, this big gap with many of these eggs remaining in storage and many fewer replacement cycles going on. So you can see, although 1,200 cryopreservation cycles occurred, there were only a couple of hundred thaw cycles, or 550, 600, perhaps, if you add the two together. And this is an important area. On the right is a paper that we've recently written with the Royal College of Obstetricians and Gynecologists, discussing this and highlighting what a positive factor this can be in the right hands. But there are, of course, all sorts of ethical issues associated with it as well. But certainly becoming an established way for preserving one's fertility in a non-medical situation. So how good is it? So again, we turn to Anna Cobo's clinic to look at some of the best data for this, and they find that in their hands, if you're under 35 and you freeze enough eggs, then there's an extremely good chance that you will be able to have a baby from this. A cumulative live birth rate of approximating 100%, which is really fantastically encouraging. Of course, as shown in the green line here, it's not so good if you're older. But what their data also really, I think, are very important in showing is that this story does not look so positive for patients who are preserving their oocytes when they have a cancer diagnosis. And you can see the difference in the two blue lines between the two graphs, showing this difference in cumulative live birth rate. And what they identify in this analysis is that oncology patients had a lower oocyte survival, even in the younger patients, the under 35s. The implantation rate was low, the pregnancy rate was low, and the live birth rate, you can see, was dramatically lower, 68% in elective fertility preservation and only 41% in the oncology patients. Now, these data will continue to mature with time, but I think this really highlights the first question, of course, is why is this, and what can we do about it? Do we need to be handling these oocytes differently? Do we need to be handling our patients differently under these circumstances? Are there better protocols to use in oncology patients to try and match what can be achieved in the healthy women shown in that left-hand graph? So the other aspect of this, and going back to the point made by Dolmans and Dene in that review, is choosing the right patient. And we've been trying to look at this on a population basis to try and get some really accurate data about what is the impact of a cancer diagnosis on the chances of pregnancy. And from that, trying to identify where really are the gaps that might be the areas that the field of fertility preservation should perhaps focus on in the future. And overall, we found that in a up to 40 years, all patients with cancer, we found that there was an overall 38% reduction in the chance of having a pregnancy than women who didn't have a cancer. And that, of course, is dependent on their age. You can see in the children up to age 14, it's the standardized incidence ratio here is 0.72, so that's about slightly less than 30% effect, whereas in the older patients, it's a nearly 60% reduction in the chance of having a pregnancy. But there is good news here as well, and that over the time that we did this study, going back to the early 1980s right up to 2012, there was a really quite significant increase in the likelihood of a pregnancy after cancer. From about 50-50 back in the early 1980s, now up to nearly an 80% chance these days. And part of that is accounted for a huge increase in the incidence of skin cancer that we've seen in Scotland, along with many other Western countries, but Scotland seems to be particularly affected by it. And that has only a modest effect on the chance of not having a baby afterwards. But even removing skin cancers from this, we still see this positive change over time. And I want to highlight, though, from this one particular diagnostic area and highlight some of the problems here, and that's women with leukemia. And often speaking to oncology colleagues after acute leukemia, particularly the common leukemia of children, they often think that their patients have a very good fertility prognosis. But our data don't really substantiate that quite as much. And you can see here on the left here, in the blue is age-matched controls, and in the red, patients with leukemia and their increasing chances of pregnancy with time since diagnosis. And you can see, because half of them are less than 14 at diagnosis and others are still in their early reproductive years, this carries on increasing over a very long time. But there is an enormous gap between them and effectively the girl next door. Much less of a gap with Hodgkin's lymphoma, and again, a very different situation with a disease that's at the other end of the reproductive age spectrum, breast cancer, where again, a very big difference, about a 50% reduction, but all concentrated into the initial years of diagnosis. Whereas, as I say, this goes on for a very long time. And if we look at the break that down in a bit more detail in leukemia by age at diagnosis, you can see that the age group who are most severely affected by this are women in their 20s, particularly their later 20s, just the time when you would imagine they're going to be just thinking of starting a family. Those are the ones who are least likely to be able to have a pregnancy after this diagnosis. And of course, that reflects the serious treatment that they require, often involving a stem cell transplant. And while we see that there have been substantial improvements in the pregnancy outcome after many common cancers, breast cancer, Hodgkin's, cervical cancer here, we can see that after leukemia and CNS cancer is the right-hand set of graphs, you can see that there has been no change over this 30-year period of time from the early 1980s up to 2012 for either leukemia or brain and CNS cancers. But we are starting to see positive results. Again, go back to data from Draw Marrow, at now successful use of ovarian tissue cryopreservation in a patient with leukemia, tissue harvested in remission. very careful testing of that tissue to make sure there was no contamination before replacement. And of course, that is the key anxiety in the situation, and wonderfully a successful pregnancy and delivery. And this really remains an ongoing major issue within the field, not just in leukemia, but it can catch you by surprise in other cancers. This was one that we were involved in, where a child had a Ewing sarcoma with affecting her cervical vertebra. And indeed, when we took some ovarian tissue, we found here that in this little piece of tissue down here, and then stained for the cancer, that in fact it had metastasized to her ovary. So it's not just hematological diseases, this can come under other circumstances as well. So my colleague Evelyn Telfer, I'm sure, is going to be telling us a lot more about this, what we can do. Can we grow follicles? Can we mature them? And to avoid this, and of course there are other approaches as well with artificial ovaries, but this still remains some way away from anyone being able to actually achieve a pregnancy from this area, although it is looking a lot more promising than it was, and I think it's still reasonable to be taking the tissue to freeze for patients with this prospect likely to come into clinical use within a more reasonable period of time than was the case a dozen years or so ago. Just in my last final minutes, I just want to shift the emphasis to the male, because I think we also need to recognize the huge advances that have been going on there. Despite semen analysis semen cryopreservation having been around again for over 100 years, a similar timescale to those very early ovarian transplant experiments I told you at the beginning, we still don't have an option for the prepubertal male in terms of actually there are no babies born from any technique preserving fertility in these individuals. But we are seeing huge advantages, and I think we're really on the brink of this, and this will be a really exciting time to be involved in this field. So from tissue, from cells, you can see that there are a number of different outcomes and options, and indeed in animal models, these are now all leading to successful pregnancies, and actually have done for over a decade. You can see actually in the middle there, now getting on for over 15 years. These have been successful techniques. But not in humans, of course. But what has really moved this a step closer to fruition is this lovely study by Kyle Ulwig's group in the States, published last year, taking prepubertal rhesus monkey testis grafts, where they put them back, either fresh or frozen. They put some back in the scrotum, they put some on the back, and in both cases they were successful in producing testosterone, as you can see individual graphs here in the middle panels, and then here on the right you can see within some of these tubules the onset of spermatogenesis, and indeed the great majority of tubules in these specimens did start to produce sperm over a period of many months of grafting. And indeed they were able to collect sperm from these tissues, inject them into oocytes. 138 eggs were injected with sperm. Only 28% of them cleaved, but those cleavage stage embryos did develop into blastocysts at a reasonable rate, and you can see here a very healthy little baby monkey born as a result. So a fantastic proof of concept that this prepubertal testis tissue in a closely related species to ourselves can go on to produce our offspring. And indeed, it really can't be too long before someone is doing this in humans and producing babies as a result, and we await that on a daily basis. So to conclude my talk, I hope I've illustrated to you that some of the key issues in female fertility preservation are still the same as those that were identified 25 years ago. And although we have progressed enormously, there are still a lot of things that still remain key stones that we kick our toes up against on a regular basis. And they include follicle survival after transplantation, and the need to get more of these follicles to survive. The majority of them we are still losing. There's a question of oocyte quality, particularly evident in the oocyte vitrification data I showed you, but it may also be the case in the ovarian tissue story, and we just really, I think, just don't have enough data on that. But if you look at the IVF outcomes from IVF cycles there's a suggestion that the oocyte quality is perhaps not as good as it would be normally. There's still the thorny issue of malignant contamination, and there are a lot of different approaches to that, including, as I say, the artificial ovary, in vitro maturation and growth, and even culturing tissue in chemicals that will remove malignant cells, which in some instances has some significant promise. And I think we also need to remember the patient here, and that we need to find the right patient for the right treatment and be able to give them accurate advice. And of course, with the developments in oncology, particularly with novel targeted therapies, those are therapies whose effects on reproduction we really know very little about, and that's a serious area for further investigation. And amongst those, I particularly wanted to highlight the challenges of the leukemic patients, where I think we really haven't got our hands, a handle, I should say, on how to really deal with them most effectively. So thank you for your attention. I just want to acknowledge my three close friends and colleagues here, Hamish Wallace in Paediatric Oncology, Evelyn Telfer, who you're just about to hear, and Rod Mitchell, who leads the testis tissue freezing program in Edinburgh, and many colleagues, both in the Tissues and Cells Directorates, who provide a fantastic service for us storing tissue, and many clinical colleagues in Edinburgh and indeed wider afield who've been involved in many of the research studies we've done to underpin a lot of what I've been speaking to you tonight, this afternoon. So thank you for your attention.
Thank you very much, Dr. Anderson, for your great presentation. Our second speaker is Evelyn Telfer from Institute of Cell Biology, University of Edinburgh. Professor Evelyn Telfer is a world very known scientist in ovarian biology. She holds a chair in reproductive biology at the University of Edinburgh and has a research group in ovarian development within the Institute of Cell Biology and Genes and Development. Her topic is folliculogenesis and ovarian biology for clinicians. Dr. Telfer?
Hello, is that me now? Okay, well, I'll get started. I don't hear any feedback, so I would like to thank the organisers for inviting me to give this presentation. And sadly, it's not in Istanbul, but I'm coming to you from the west coast of Scotland. And I'm going to talk about follicle development. So originally, Özgür asked me to talk about follicle and oocyte development, but within the context of mechanisms for fertility preservation. So mainly looking at what we've learned from the tissue that comes through fertility preservation, and to hopefully develop in vitro growth systems for that tissue, as Richard has so elegantly spoken about in the previous presentation. So oocyte follicle formation then, in terms of the development of the ovary, is before birth. So during fetal development, we have the primordial germ cells that migrate to the gonadal ridge, and they then form the oocytes. They will be dividing, they will form the oocytes, and they will be surrounded by somatic cells that will become the granulosa cells. And these oocytes, they enter meiosis, and they get to the dictate stage of prophase 1 of meiosis, and then they're arrested at that stage. So at that point, the follicle is a unit that contains the oocyte arrested at the dictate stage of prophase 1 of meiosis, surrounded by a few flattened somatic cells, the granulosa cells. And this forms a population of germ cells that must last the human female throughout her reproductive lifespan. Now, we've known for a long time that under normal physiological conditions in the human, there's not a new population of oocytes that are formed. But that's not to say that there's not cells there that have the potential to form them. But under normal conditions, we have this store of primordial follicles, and that must last the female throughout her reproductive lifespan. So we have this, the pool, the primordial pool, and then through a variety of signals, there's inhibitory factors and stimulatory factors, these follicles will start to grow. So they're initiated or activated to grow, and the oocyte will start to increase in size, and the granulosa cells, the somatic cells, will start to proliferate and form these multilaminar structures known as the preantral follicle. And this is all happening actually before birth in the human. There's growth of follicles, but this is the utilization of that pool that was laid down before birth. And then the follicle, when it gets to this preantral stage, that undergoes this morphogenetic transition where it starts to accumulate fluid within the cells, and it forms this fluid-filled cavity, the antral cavity. And then we have a differentiation of the granulosa cells. And at that point, we have the cells that surround the oocyte, the cumulus granulosa cells, and the cells that surround the wall of the follicle, the mural granulosa cells. And then, of course, there's the stromal cells, the theca cells that would be in the outer part here of the basement membrane, and they would be connected to the vasculature of the ovary. So the blood vessels would only enter within the theca layer, and this area would be completely avascular. So these follicles then, the most important thing is that to support the oocyte growth and development, you require connections between the oocyte and its surrounding somatic cells. So the somatic cells then have to be in contact with the oocyte, this cumulus layer. And many factors can interfere with those connections. And if the connections are lost, then that results in a degenerate oocyte. So this is a complicated process, with the formation of follicle pool and then the regulation of the activation of the follicle pool and the growth of the follicles to a mature stage. Now, in humans and in cows and in sheep, not all sheep, but they're monoovular species, so only one follicle would ever reach this stage of development. And during this whole phase of growth and development, then the oocyte has to grow. It has to be maintained in meiotic arrest. So all of these stages, that oocyte would be at the dictate stage of prophase 1. But it also has to acquire the ability, the competence to resume meiosis when the correct signals are there, so just before ovulation. So it has to acquire that ability, and it also has to acquire developmental competence, so a collection of factors that will support the early embryonic fertilization and early embryonic development. So there's a lot of processes that are happening during this process of follicle development. And of course, towards the end, there's transcription and transcriptional repression. Then there's genomic imprinting that is happening at all stages, depending on the gene that's being imprinted of follicle development. So it's an incredibly complex process. And in actual fact, there's so much that we don't know about the process of human oocyte development. But actually, this whole development of the field of fertility preservation has given us a window into some aspects of human egg and follicle development. And as Richard said, of course, the work in Edinburgh that led to ovarian biopsies that could be taken and then frozen, which now occurs worldwide. And we have these ovarian strips. And of course, as Richard also said, the transplantation of these strips has led to over 150 live births. Now, Richard also showed that in some cases, the tissue that's stored may not be suitable to be transplanted because of the presence of malignant cells. And there's been a lot of work in developing artificial ovaries, and that's the work of Marie-Madeleine Dolmans and Jacques Donnet and Cristiane Amorini. But we've been working on another method that maybe avoid the whole process of the risk of transplanting tissue or indeed follicles that may have contamination of malignant cells. And that's essentially lab-grown eggs or lab-grown follicles. That completely or would completely avoid the transmission of malignant cells because we would grow them entirely in the lab and fertilization would occur in the lab, and then it would be transfer of the embryo. So tissue freezing, as you've heard, has been in Edinburgh since 1994, and now there's centres worldwide. So when we look at this tissue, the tissue that's removed and stored for fertility preservation contains predominantly primordial follicles. So this is pieces of ovarian cortex. Of course, some centres freeze whole ovaries, but remove it into pieces. But the cortex of these ovaries will contain predominantly primordial follicles. And these are some growing follicles that are present. So the challenge then that we have is, of course, to develop a system that would allow the growth and development of these primordial follicles entirely in vitro to the point where they can be matured and fertilized and form embryos. Meanwhile, though, by developing such a system, we can learn a lot more about human follicle and oocyte development. So the strategy then is to follow the process of follicle development that we see in vivo, in vitro, but not recapitulating all of the stages, or indeed not recapitulating all of the timings that we see in vivo. So the first stage then is to optimize the growth from primordial stages. So to activate primordial follicles that can subsequently go on to be competent, healthy follicles and produce good quality oocytes. And then supporting the development of these isolated growing follicles. So once they get to the preantral stage, we would support their growth and the factors that would support development of the oocyte. But the most important point at that stage is the maintenance of the oocyte somatic cell interactions. So ensuring that there's good connections to allow development of the oocyte. And then, of course, we want to develop the final stages of oocyte development and make sure that we can get them to mature and then hopefully be fertilized. So the final stage would be testing their function, their meiotic potential, fertilization potential, and whether they were normal or not. So for a number of years then, we've been developing a multi-step culture system to support human follicular oocyte development. And essentially, we've taken the approach that I've outlined, the activation, growth of the preantral follicle to the antral stage, growth of the oocyte with its surrounding cumulus cells, and then looking at maturation. And so far, we've not looked at fertilization, but that's clearly the next step. So optimizing the growth of these primordial stages then. So this is just to show you the tissue that we get. This is small pieces of the ovarian cortex, and we then prepare it in such a way that we refer to as a microcortex. So we remove we flatten out this tissue, and then we prepare small pieces and we stretch these pieces to support activation. And in the first instance, we really had no idea why this triggered activation of the primordial follicles. We just knew it did. And the reason we did it was because everyone else was culturing pieces, dense pieces of ovarian cortex, and they were not having very much success. So we hit upon the idea of maybe flattening and stretching. And that's exactly what triggers the activation of the primordial follicles. Now, we now know that we're activating or we're disrupting the hippo signaling pathway. And by disrupting that particular pathway, we can get more follicles to activate. And therefore, we can obtain many more growing follicles than we would normally see if we just left it to the normal situation of keeping the primordial follicles in a dense structure. Now, what that tells us then is the importance of another signaling pathway, the PI3K pathway. And we know that there are components of this pathway that, that regulate the inhibition of follicle activation. So this part, the P10 part of the pathway, inhibits activation of the follicles. And this part of the pathway, the mTOR part of the pathway, is part of the regulation of activation of these follicles. So we know that we can pharmacologically manipulate these factors so that we could block P10 and therefore allow more activation, or indeed you can block mTOR to hold back activation. And we've done this in the human tissue and in cow tissue. And of course, you'll be aware that group in Japan and Erin Shui in the US, they've used this model system clinically to assist in vitro activation before transplantation. And they've been able to produce live young from tissue that previously was not activating at all. But I have to put here a note of caution, because in the culture model, whilst we do absolutely get more follicles initiated to grow, and we get more growing follicles when we inhibit P10, it comes with a cost. And that cost is that we have increased DNA damage and we have impaired DNA repair capacity. So I would say that with the in vitro activation, by manipulating a P10 pharmacologically, we have to be cautious and gain more information about the consequences of the in vitro activation protocols. And that's part of the work that we've been doing in collaboration with Richard, and we've had a student from Indonesia, Mila Maidarte, working on this process as well. So that's given us quite a lot of information about the process of primordial follicle activation. Now the next stage is the growing follicle stage. So isolating these growing follicles. And what we do is, when they get to a preantral stage, we can isolate them and grow them individually in culture. Now, we isolate them mechanically. We do not use enzymes. And the reason we do not use enzymes is because the enzymes have a bad effect on the preantral follicle in our hands. And we grow them individually in a V-shaped well so that the follicles are not talking to one another essentially, and they're not inhibiting one another, because that is what happens in vivo. And we do not use any matrix. The work in the US by Teresa Woodruff, they use an alginate matrix. We do not use that. So it means that it's relatively straightforward to culture and also to remove the follicles afterwards. And what we find is that we see antral follicle development after, if we put them, the isolated follicles after 6 to 8 days, step 1, and then step 2, between 8 to 10 days, we will be seeing antral cavities formed in vitro. And the key to that step is the maintenance of cell-cell communications. And what we found through our work on the bovine ovary and also in the human ovary is that we need the presence of activin, and we also need a low dose of FSH. And it's essential that we do not use high doses of FSH at that stage, because high doses of FSH disrupt the communication between the cells, and that results in a very, very poor quality follicle and really a degenerate oocyte. So the importance then is of understanding when to add the factors that will facilitate follicle development and oocyte development, and in the appropriate concentration as well. So we then take these antral follicles, and what we've decided that our strategy would be is not to try and grow these follicles to be very, millimeters in diameter. What we've decided is this is an endocrine structure. The purpose of the large follicle is to produce estradiol, but we're interested in the oocyte for the purpose of the in vitro growth technique. So what we do is we remove the oocyte and its surrounding cumulus or granulosa cells, and then we place them on membranes and grow them for a further period of time before placing them in maturation media. So this means that we are not allowing the long the extended period of growth of that large antral follicle. And of course, you can argue whether it needs that or not, but we would say that it does not need it. That when we take the oocyte cumulus complex, you move it and you place it on a membrane, then we place it in maturation media. We have been able to get metaphase 2 oocytes from this. So we get the formation of a spindle and we have a polar body formed. Now, this has been published, of course, in 2018. It's the first time that there's ever been a mature oocyte all the way from a primordial follicle grown in vitro, a human one. This can be done in mouse, but it's never been done in human before. But you would see, or most of you will recognize that that polar body is rather large. And that's been a concern for us. So in our multi-step culture system, if we use healthy adult tissue, and most of this tissue has come from women at the time of caesarean section, we can get about 30% of the oocytes that complete the culture process will reach metaphase 2. We're now looking towards testing a range of tissue sources. So looking at our healthy women, we can get that to metaphase 2. We've looked at prepubertal girls, and we published a paper, and Richard is first author on this, where we looked at our culture system and the growth rate of follicles at different ages. And what we found was that mature tissue grows at a different rate, or follicles from mature tissue grows at a different rate from follicles that are taken from younger tissue. So there's clearly a difference in terms of prepubertal tissue and getting close to puberty and then adult tissue. And that's something that we're working on to tailor-made our culture system for that kind of tissue. We've looked at Turner's patients. We've looked at chemo-treated tissue, which is variable depending on the age and treatment that we use. And we're currently looking at gender reassignment tissue, in which we can get metaphase 2 oocytes from. But the key is, one size does not fit all. The system has to be adapted for our tissue type, so our patient group. So moving this towards an application by improving our culture conditions. The human in vitro grown oocytes that I showed you, they all formed metaphase 2 spindles, but they had large polar bodies. And so what we've been doing now is adapting our physical conditions of the culture system. And the main component that makes a difference is lowering oxygen tension. So by lowering oxygen tension, we seem to be able to improve. Now, this is very preliminary data I'm sharing with you, but we do seem to be able to improve the polar body size and the spindle. And that's, of course, ongoing work to ensure that we can optimize the system. The next steps that we're taking then is to determine the health and developmental competence of these in vitro grown oocytes. Hopefully when we get approval and once we've optimized our system, we would go for fertilization. We don't want to fertilize or attempt fertilization in a suboptimal system. And then the next stage would be embryo testing. But we also have ongoing, or in fact, starting a big project on our large animal model, the sheep, to look at the ability of in vitro grown sheep oocytes to produce embryos, and then we'll do embryo transfer. So a lot of work is ongoing to try and bring this towards clinical practice, maybe, you know, in 10, 15 years' time. So we've published a lot on this. We've used it to get basic information about human oocytes and human follicles, of which we really knew very little. We've looked at the effect of age, chemotherapy, and the role of signaling pathways. And we're now using this to study the potential to generate new oocytes from putative germline stem cells and also from induced pluripotent stem cells. So I would just like to acknowledge the people that do the work, the people who fund us, MRC and the Wellcome Trust, and of course my clinical collaborators, Richard Anderson, Hamish Wallace, and the people who are the patients who kindly donate their ovarian tissue. And I'll leave you with a view from where I am now in the west coast of Scotland. And thank you very much for your attention.
Thank you, Evelyn, for this great talk. Our next speaker was Javier Santamaria from Spain. However, because of the speaker's technical connection problem, he's not going to give his talk today. So we are taking 2 questions. And one of the questions is, what do you feel about the future of in vitro culture system? Do you think they will be capable of supporting the growth of isolated primordial follicles for full growth into ovulatory stage?
So I can answer that question. So firstly, isolated primordial follicles do not seem to grow very well in vitro. You have to have them within the context of the ovarian cortex. That is very important. So that's why in step 1, we have the ovarian cortex and these pieces, and we prepare them in such a way to get activation and growth. Do we want to produce them to ovulatory stages? No, we don't. We want to produce competent oocytes. So that's why we remove the oocyte and its surrounding granulosa cells at a stage where we can, you know, support their growth and development, their meiotic potential, and hopefully they would be capable of fertilization. So the short answer to the question is, I think, yes, it's absolutely possible that we will be able to take primordial follicles all the way to fertilization and embryo production, but we've got a lot of basic studies to carry out before we get there.
Okay, thank you so much, Evelyn. And the other question is, some groups are using bone marrow derived stem cells to provoke the dormant follicles in premature ovarian insufficiency patients. Do you think that it's a promising approach for a wider use?
I think it's a very promising approach. So we've also been working on mesenchymal stem cells. I think the thing that you have to be careful about is the making sure that you have a very clean population of cells before using them for either experimental or clinical purposes. And I think, unfortunately, many people who have carried out this work have not had pure populations of cells. So I think it is a promising approach, but still there's a lot of characterization that needs to be carried out.
Okay, thank you so much. And that's all for today. We all thank you. And tomorrow our sessions are going to be delivered again at 5:30. And we again wait all of your participation. Good night.
Good night.
Thank you.